Dr. Levy, if you'd like to introduce, please go ahead. If not, I can do it for you.
Go ahead. I think, is Dr. Joshi on?
I don't see him on yet. We can wait another minute or two if you'd like to.
Megan, is Dr. Joshi going to?
Ms. Romulote, I'm with the FedEx Institute of Technology, and very happy to have Dr. Yuri Quintana, I believe I'm saying that correctly. If not, yeah. He's joining us as the chief of the Division of Clinical Informatics at the Beth Israel Deaconess Medical Center and as assistant professor of medicine at Harvard Medical School. His research is focused on innovative technologies that empower communities of healthcare professionals and patients to collaborate on a worldwide basis. He teaches courses on global health informatics, e-health, and serious games for health. And with that, I'll turn the floor over to him and let him present. Thank you, sir. Pleasure to have you.
Great. Thank you so much for the invitation, and happy to share the work that I'm doing with colleagues both here in the Boston area as well as other parts of the United States and Europe. So today I'm going to talk to you about an initiative called InfoSAGE that we've developed over the last 10 years here in our division. And a bit about our division, founded in 1970, one of the first divisions in the United States to use technology to improve healthcare, and has played a key role in the formalization of informatics as a formal discipline that is studied, and you can now be board certified as a subspecialty in informatics. So a lot of the founders in our division, it was founded by Warner Slack and Howard Bleich, and subsequently led by Charles Safran. All of them were instrumental in helping to promote the use of informatics as a formal discipline to improve healthcare in a systematic way. For disclosure, the InfoSAGE platform that I'm going to talk to you has been developed with funding from AHRQ, a US government agency. I will occasionally mention a few products, but they're just for illustrative purposes. There's no commercial relationship with any of these particular products. We have received some funding for telemedicine work from the Office of Rural Health, and I am part of 2 European Union grants called Gravitate and Unicom. So as I mentioned, the platform was, the division was developed by Warner Slack, who was one of the early champions of patient empowerment, and wrote some of the first books on papers. He believed that technology needed to be used to provide information both to doctors, nurses, but also patients and their families. And he noted that the most underutilized resource in healthcare is the patient. So he advocated providing access to medical records using technology to ask patients about their symptoms and preferences, so that when you actually went to see your doctor, they could actually spend the time talking about what was important to you, not having you fill out forms. And it's very visionary for him to do that. Unfortunately, now in 2022, you still go to the hospitals and clinics and spend a lot of time filling out forms instead of actually spending quality time discussing it. So Warner Slack has sort of influenced a lot of us who have thought of how to design systems in a less paternalistic way, in a more open and access sort of way. So InfoSAGE was built on that, and we started looking at what are some of the major challenges that are facing both our medical systems and public health organizations. As you all know, chronic diseases is growing worldwide, and it's representing not only a large amount of frequency of occurrence worldwide, but it's also costing an enormous amount of money. It's impacting the ability for companies and governments to function. And unless we do something about that, it'll be very difficult to have a stable economy. Certain diseases and conditions like diabetes fall within the definition of what is known as an epidemic, affecting millions, if not billions of people worldwide. Treating all of these chronic symptoms is causing healthcare costs to rise considerably worldwide. It's a problem not just in the United States, but everywhere. And there's also a shortage of providers. So the number of people graduating from both as physicians, nurses, social workers, has not been increasing at the same rate that our population has been increasing. So every year we have to figure out how to give care to more people with just not as many people per capita in the area. And the problem is even worse in developing countries where the ratio is incredibly bad to be able to get access to care. Coordinating that care among all of the different providers is very hard. As you know, we have a very fragmented both medical and public health system. And so as we have different providers, it's very difficult for any one provider to know your full medical history since we don't have interoperability. Aging is a particular problem for our society because we have a growing aging population, not just here in the US, but worldwide. And in many places, the global population will double or triple over the next 2 decades. And so we're going to have to, people are living longer and with more chronic diseases. So we're going to have to figure out how to treat more and more people. People have envisioned this problem for a long time. And over a decade ago, a think tank called Leading Age advocated the need of developing systems that could integrate and help coordinate care, particularly for older adults. They wanted to have better information sharing, be able to have more telehealth. And despite all these visionary roadmaps, we really haven't built out a system that is truly helps connect providers together with their patients and their families. And this became self-evident when we had the pandemic and we had to rapidly move to telehealth, and nobody actually knew how to scale that in an effective way. There are certain problems, particularly with older adults, that are causing enormous outcome problems and cost problems. For example, medication adherence is a problem worldwide. And in most countries, including ours, adherence to those medications, being able to take your medications as prescribed, less than half of the people are actually taking those. And the problem is that those adherences are a major contributing factor to treatment failure in at least half of the treatment failures that have been analyzed. So we have failures, people that have longer health conditions. We have people who are dying because of inappropriate administrations of medications. 25 of hospital admissions are due to some form of non-adherence. All told, this is costing over 15 billion in hospital admissions and over 31 billion in nursing home admissions. So clearly, I think we need to do something about aging care, in particular medication adherence. It's particularly difficult because not only are there people taking more medications, the medications are getting more complex, have more side effects. We also have a health literacy problem that I think all both schools of public health, medicine, and governments should pay more attention to. 12% of the population in the United States are not at a proficient level of health literacy, which means the basic ability to understand, process basic health information. And this could be to understand when to take a medication, or what are the dangers of mixing medications with other substances. So here you see a chart. There have been numerous studies replicating this data. It really hasn't changed over the last 20 years in any significant way. We may actually be getting worse. And if you start breaking it down into different levels, here you see that 14% are below basic level. And these people just are not able to even understand things such as basic instructions of when to take different medications and whether they have to take it with food or without. So and then if you go even just to the basic, that's another 21%. So all told, a third of the population is struggling to understand this information. And that's a big portion, a reason why we're having problems with medication adherence. The labels are also difficult to understand. So here's an example of a label that would be attached to maybe your box of medications. And while there has been work to try to figure out the layout of that information, it's still a lot of information to process. And if you open that box, what you'll find inside is usually a piece of paper that unfolds like origami, usually into about 1 or 2 feet, usually in 10-point font, very dense, most people at a very high reading level, most people don't get through the first paragraph or two of this. And somewhere buried in there are the drug-drug interaction and warning information. So no wonder people aren't quite understanding their medications. It's a lot of information. You have rushed visits at the hospital, and we're not actually communicating that. If you look at the drug-drug interaction information, it's very complicated, and they list a lot of different drugs. And here's an example of people who are trying to visualize all the interactions that there are between different types of active ingredients within drugs. And with most older adults taking 5 or more medications, the number of potential drug-drug interaction alerts is a lot. So how do we explain this to people? Which drug-drug interactions are ones that they should concentrate on given their age, gender, and clinical condition? We don't have a way to filter and rank those, neither very well for health professionals or for patients. Some of them have started to appear in some medical records, but most providers feel overwhelmed with all the alerts. So we really don't have very good filtering at this point, and nothing like that exists for consumers. So we decided to look at this problem of older adults and aging communities and how to help develop technology to help those older adults, frail older adults, manage their condition, but not only help them, but also their families, because as you increasingly become older, you depend more and more on family caregivers to be able to care for that. And we know that a large number of older adults depend on one or more of their children to help them, or close family members to do that. So how does that informal caregiver community coordinate their activities for helping that older adults? How do we do care coordination? And how do we do it in a way that respects what the elders' preferences are? We also have to understand that this is happening in the context of a very fragmented system. An older adult probably has more than one health specialist that they're looking at. They may have multiple visits to the emergency room. They may be accessing medications, both from their hospital, but maybe different pharmacies. And so it's a real challenge to manage all this information from multiple sources. And so what we wanted to do was to develop a system that could help best communicate information to patients and their families about medications, when to take them. We wanted to understand what's the best way of using technology to connect that family network. Where do they go to access the latest information, and how do we make sure it's available at different levels of literacy? How do we make sure that it can work on different types of devices? And finally, can we use this type of technology not only to help them manage their symptoms, but collect patient-reported outcomes that could be used to be able to help understand how safe medications are, or what symptoms people are experiencing that might require new medications or improved medications, something that is known as sort of real-world evidence data. So we looked at some of the data, and it did show that a very large percentage of the population did have technology. Not all of them, but most of them do. But an interesting phenomenon happens that as you go beyond 65, the usage of that technology drops off considerably, and especially when you get over 75. You may have a phone, but you may not be using most of the functionality of that phone. So the way in which you design the technology for 75 and older has to be extremely useful. And that gave the genesis for the InfoSAGE project. As many of us had family members that are aging, and we were in the informatics and technology space, and going back to Warner's idea that the least used resource was patients and their families, we decided to sort of tackle this problem in an informatics type of approach, systematically thinking about what are the requirements and how to evaluate those solutions. So some of the requirements that we came up with is that we felt that we needed a way to improve communication among family caregivers. We needed to make it easier for patients and those caregivers to understand the medications and be able to display that information in the best possible way so they could understand those medications and safely take them. We wanted to make sure that they were accessing authoritative sources of information. We want to make it easier for them to update that medication list which is a problem when you have multiple providers who are giving you those medications. And then if you're traveling, how do you actually get a prescription refill in a different state or country if you run out of the, how do you make sure that they get not only the right medication, but a medication may have the same name across two different countries, but the active ingredient may be at a higher concentration in another country. So how do you warn people like that? And that gave us some ideas to collaborate with people in Europe, and I'll mention some of that in a moment. So the InfoSAGE platform was developed as really as a way for you to be able to create a private social network where you help create a network that includes your frail elder. That frail elder can decide who are their family members, and then you can give different roles to those family members. Some of them might be caregivers, some may be acquaintances, but we wanted to be able to develop this in a way that would allow you to create a caregiving support network that would help you manage your medications, your reminders, help you understand how to manage those symptoms, and how that care team would sort of help manage different tasks, such as helping you go to your hospital visits or for your rehabs or getting refills. So we wanted to have better communication tools. We also wanted to do it in a way that would be respectful of how elders wanted their privacy to be handled. So we did this as a co-design approach. We held several workshops with patients, their families, different nursing homes in the Boston area. And we worked also talking to different groups that provide services for at-home care. And through that, we came up with lots of ideas that they were giving us. But the one thing was that elders sort of said, I want to be able to share information, but I want to know who I want to share, and I want to be selective what I want to share with them. And so from that came the idea of a flexible system where you could choose who you included in your network and what they would access. We went through several rounds of iteration of designing both a web-based platform and a mobile app. Here you see some of the main functionality, where on the left, you see different tasks that people can sign up to do. These are family members that are part of the care team. So you can sign up and see who's going to do that task. You can see the medication. The actual frail elder can see the same thing as well. But if you have an older adult, especially if they're in cognitive decline or have dementia, then you need family caregivers to help them remember when to take those medications and how to take them safely. We built also a mobile app for iOS and Android, and we did several rounds of testing, and there's a couple of papers evaluating the usability of this. One thing that became clear is that no matter how many improvements we made, it's still complicated to add lots of medications and some of these drug regimens, and when you're supposed to dose, dosing is complicated. So we've made improvements, but there's a point at which we feel that the next generation of this is really going to have to be some sort of voice-activated system that you'll be able to ask when your medications, ask questions about it, and be able to then enter your medications also through verbal. So we're working on natural language interfaces for this. There are different, here it shows you some of the different roles you can have within InfoSAGE. So the keystone is the main patient, the older adult. And while we built it for older adults, it could be used for any condition, anyone who has a family caregiving community. Proxy is someone that has is designated by the keystone to be able to do all the functions that they would be able to do, invite people to be part of the caregiving network, and to manage permissions. Caregiver is someone who has access to the medication information and other medical information about the patient and is involved in providing care. And while normally at this point it has been informal caregivers, there's no reason that couldn't be also a formal caregiver, such as a visiting home nurse or a physician or nurse or social worker from a healthcare system. And participant is someone that just wants to stay in touch with the family member and get updates on their condition. So some of the features of this is we work really hard on coming up with a flexible way for you to be able to control privacy. The task management was one of the first things that people wanted. People also wanted to know what are the resources for aging in their area. And so we curated a list of resources that we had from the region. One of the problems we found is that maintaining the list of resources is actually very time consuming. No one seems to have a really good up-to-date list. There's some commercial providers now that do that. And I think one of the interesting things that we're interested in is how do we connect the right people to the right resource, and does that actually help us? How do we know, how do we keep that current and useful and valid? So we've got a project looking at that, that aspect of curation and evaluation of curated resources. It connects also to a database here in the United States called RxNorm, which is maintained by the US government. It has all the drug medications there. One of that's maintained by the National Library of Medicine. One of the interesting things about that database that it has drug-drug interaction alerts. And so we've imported those and we display them on InfoSAGE. And there are commercial ones, but I think it's important that the nation have a free version of this. And so we've connected the Rx norm. And it also has drug medication information, but again, those medication labels currently are not optimized for lower literacy levels. And I'll speak a bit more about that in a moment. We looked at the usage patterns, and surprisingly, the keystones, which the majority were 75 or over, were able to use the website. Here you see the number of logins, which were almost as high for both non-keystones and keystones. There were slight differences in how the system was used. The keystones were more involved in inviting people to their network. They're about equal use between keystones and non-keystones for viewing medications events. And the task in terms of signing up for tasks and doing things, most of that was done by non-keystones. So we were generally happy that we were able to create a useful system. When we looked at how often it was used, it was somewhat transient in that most of the heavy usage seems to be along certain moments of spike. And this could be maybe when medications have been changed, or there's a difference in the condition of the patient and maybe requires more family members to be involved. But we saw generally spikes in usage. We also saw spikes in usage over time. And so not surprisingly, for some of the caregivers, some of that was older, connectivity was done in later points of the day. And it's interesting which days and times was used. We also looked at the structure of different family networks, and there were over 500 families on the network, and we thought maybe there'd be a certain pattern that dominated, and we actually found a whole range of family networks. And here it shows you some of these. In some cases, there were two keystones, could be two people that were married who shared the same proxy and maybe the same caregiver, and that you see on the left-hand side. Then there were other situations where there were two keystones where they would share some proxies but have slightly different caregivers as well, and an overlap of proxies but not the exact same. So it's obvious that every keystone had a different situation and wanted to have different people in their network, and they can do that within this platform. As I mentioned earlier, we have been working on voice-based interface. We did a prototype using Alexa devices, and while technically this worked, one of the challenges of using any of these NLP systems is ensuring the privacy and security of the data. And some of these providers are not certified for storing the data securely, and they don't have assurances and to be able to store the data. So lots of things could be possible. The greatest power for processing is on higher end servers, but then you have to have a provider that is clinical grade and has the certifications for data security. So that's a major challenge and concern to be aware of. We also implemented this in different languages, and there's a version of InfoSAGE that's in Chinese that was implemented in Taiwan. We also started looking with different groups about the issue of patient equity and how do we make sure that more and more people truly understand those medications. And we're part of two consortiums. One of them is called Unicom, that's trying to link national drug databases across Europe, and we're involved with that. We're going to help connect RxNorm to the European consortium. And that's so that it has a unique drug identifier that can be mapped across countries. And then you can look up things such as the active ingredient where it's the same or maybe stronger in one country. So same drug, same name, but maybe you have to give a warning that the concentration is different. We're also working with another European consortium called Gravitate Health that was very interested in making sure that the labels could be read by patients at different levels of a literacy level. And that's an interesting consortium because they have several, both academics, governments, and pharmacy groups. So they have Pfizer, Merck, and a few other pharmaceuticals. And so we've been dialoguing with them of what's the optimal way of creating these labels so that people can actually understand them. And so we took one of the labels from Pfizer with their permission, and we put it in InfoSAGE, and we've been prototyping different versions of this label. One of the, both for font size, how it's displayed, but one of the major challenges is actually understanding the text, right? Because it's at a fairly high level. So we've started working with video-based narratives to describe that. And it turns out that the actual label is regulated by the FDA. The FDA only has a standard for print-based labels. They do not have a standard for electronic labels. So we've been engaging with different stakeholders to see if we can have an update to how medication labels are approved, such that we not only have a standard for text print-based labels, but electronic labels that could have, as part of the description, alternate ways of presenting the same information. So say if you can't read it at all, you're not going to be able to understand anything in that label. So why can't we then include an FDA-approved video that describes that label? And so we've engaged in discussions with the FDA and other stakeholders, and we're organizing a webinar later this year to bring different stakeholders to help develop a standard. And HL7 is also involved in this. The Japanese are trying to develop new standards, as are the Europeans, and we're trying to stimulate the discussion here in the United States. So what have we learned from these systems? We've learned that it's possible to use this technology to create online communities of care. Through iterative designs, we've been able to improve the usability to the point where people over 75 have been able to connect to the network, share medical information with their caregivers and family members, and be able to communicate. We found that the families, while we initially did it in the Boston area, it was open for anyone to sign up. We've had signups from around the world, and the families are actually come from both within Boston and globally as well. So there's no one particular pattern. But even in a city like Boston, which is fairly large, people can find a benefit from this because, you know, crossing the entire city to see family members is difficult. And so I think this is helping to connect families and provide better care coordination. And we were able to improve the usability, but there's a limit to what you can do with that. And so the current limits is those text labels are going to have better graphics and video-based descriptions and different alternate descriptions. And we are going to have better interfaces that go beyond just point and click. And so we're looking at voice-based interfaces for that. So as we built this as a standalone network. So it's not tethered to any one particular hospital. And it turns out that in theory, you can connect InfoSAGE to a hospital care system and import the medications. And there are technologies such as FHIR, which is an interoperability standard to connect mobile apps to medical records. There's still a process of authentication that you need to do. And many hospitals are very leery of letting anything connect to their system or their medical record. So it's no easy task to do that. There is a legislation that was passed earlier this year that reinforces previous laws, and it was called the 21st Century Cures Act, that reinforces the right of patients to have access to their medical record in electronic formats. And it has to be the complete record. And so there is some deadlines for hospitals to be compliant. Some of them are partially compliant. They export some of the data, but some of that data that's exported is really not in a particularly usable format. Sometimes it's an export of a PDF or hundreds of PDFs or different file formats. And so I think we have a long way to go to make sure that these exports are actually parsable and importable in that. And we're going to have better ways in which we can agree how to authenticate connections. A lot of hospitals were very concerned that not only the patient is downloading their data, but they can also share it with other family members. And so then they said, how do we authenticate the family members that are part of their network? And we said, well, that's not your job. You know, if somebody accesses their information, they have a legal right to share that with whoever they want. And the 21st Century Cures Act reinforces that. Still, it's still a real challenge to get these kinds of systems connected to any healthcare provider. And so until we solve that, we're going to continue to have a very fragmented manual part of the system. Now, about 15, 20 years ago, the Institute of Medicine, which is now called the National Academies of Medicine, came up with this concept of the learning health system, with the idea that you would be able to standardize certain evidence-based treatment methodologies and healthcare delivery methods and test it within a certain healthcare system. And then as the evidence grew, be able to scale it across the entire healthcare system. And it's really been a great idea, but very much a work in progress because we have a very fragmented system. And to integrate the learning healthcare system across and a large hospital care system like ours, where we have 13 hospitals and 17 affiliates, is super complicated because we have multiple medical records and different authentication systems. It's even harder if you try to do this at a state level or a national level. But it's getting in the way for us to actually be able to aggregate data to understand what works or what doesn't. So think of how you could massively improve the safety of medications such that not only you'd be able to learn from adverse events from medical record data, but what if we could access symptoms at home from patients who are collecting that on a routine basis? So there have been several grant calls over the last 10, 15 years for patient-reported outcomes. And people have developed really innovative solutions that are standalone. But the question now is, how do we integrate those systems into the healthcare system until they become part of routine care and we can be able to do interoperability across a larger number of systems? What's interesting is that this paper written in 2007 wanted us that by 2020, we would have a learning healthcare system that was so well connected and we have such great data that 90% of our clinical decisions would be supported by accurate, timely, up-to-date clinical information and reflected the best available evidence. But we're actually nowhere near there. We actually don't even know how close it is because we can't aggregate the data for outcomes. And so several groups have started to sort of promote larger standards that would be adopted, such as standardizing the format of medical record. There's a standard called Odyssey, or an organization called Odyssey that developed a standard called OMOP that allows you to standardize the data model for medical records. There are other groups trying to standardize terminology and interoperability. But I think we have a long way to go there, and we need roadmaps of how do we build an aging learning healthcare system. And that's one of the things we're deeply interested. So we've developed a platform called Alicanto, which is really a communication integration tool for a learning health system. We have several of these Alicantos deployed through Harvard hospitals. This is the one we have at our hospital, and it was deployed for the cancer community. We interestingly developed this and deployed it in 2019. The first user started in January 2020. And if you recall, January 2020, we started having some reports of some strange virus in some parts of the world. And by March, of course, we were in the pandemic. And so we went from about 50 pilot users in Alicanto to 700 users in 1 week. And we created virtual teams to connect our main hospital, Beth Israel, Deaconess, with those other 12 allied hospitals. And the cancer group was one of the ones that was able to best manage the coordination of patients across the network, in part because they have great communication tools to be able to standardize their care. They had begun, we had merged with another healthcare system, and we became the second largest provider in New England. And so they had started the process of standardizing care and moving towards a learning health system. But I think you need really great tools and people who actually want to collaborate. And so this is what this tool really is about. It's about helping to break down those silos that there are in healthcare. It's both a combination of an online learning platform, a group collaboration tool where you can share securely documents among health professionals, access the latest treatment guidelines. It has virtual tumor boards to discuss difficult to treat cases, and we're now working on implementing tools for better referral of patients across the network, but also to clinical trials. And so we continue to add this. It's named Alicanto because my heritage is from Chile, and there's a mythical bird in Chile called Alicanto that glows in the dark and helps miners come out of mines. And I think healthcare is sort of like that. We have these huge silos of mines, and people don't even know who's in the next mine. And so Alicanto is trying to bring light and connect people and be able to have better communication. So we had great success on the clinical side with Alicanto, and we now want to build an Alicanto for home-based care. And how do we connect all of those different technologies like InfoSAGE that are doing great things in the community for patients, but how do they connect now to the healthcare system? So that's one of our major initiatives. There's a whole range of technologies for home-based care, but also for home automation. So there's things that you can buy, right, for security, for your for your home. A lot of them are internet enabled. There's a subset of this that are focusing on home-based care. And there's a whole range of companies trying to do this. And so while I think it's great that we have more technology, it's more affordable. The question is, how do we make these secure? How do we make them clinical grade? And how do we not create more silos? How do these different systems connect to each other? We could end up with 1,000 or 10,000 silos and make the problem 10,000 times worse. So we need a roadmap for how to do this. We need to also make sure that the devices we're connecting for wearables are of clinical grade. The FDA is moving in that direction in terms of setting better standards for that. And we need to make sure that people's experience of using these home healthcare technologies has high, not only quality of data, but people have a good experience using this. So we have a project with the Veterans Affairs Agency. We're evaluating and developing patient satisfaction and patient experience validated surveys that can be used for people using telehealth. And in this case, we're piloting it with traumatic brain injury veterans. And we're doing this both with English and Hispanics, and we're validating the Spanish version of these patient experience surveys. So I think in the future, these home-based care systems have great potential, but I think we need to design them, co-design them with patients and families so that we have the features that are important to them. I think we need to make sure that we support that communication between patients and their family caregivers. And increasingly, it'll be a challenge to make that connection also with providers, but I think that needs to also be done. I think we need to personalize these services. So things such as medication labels need to be tailored to their reading levels. And we're going to have to figure out how do we highlight the most relevant part of that label. So say, based on your age or your clinical condition, how do we highlight that one paragraph that maybe they should read first in that label? And how do we do the informatics back-end coding that supports the front-end filtering that does that? So that's, it requires a lot of architecture and thought design for how to do that. I think accessibility will be an ongoing challenge. What are the form factors? What are the interfaces? And while I'm really excited about wearables, the potential, not everybody actually wants to wear something all day. And so there's a bunch of companies developing ambient sensors, things that are cameras that look at how you move, and other devices that are more built into the actual fabric of the home, and trying to do with the patient's consent, an ethical way and a good, effective way of collecting those biometrics with different devices. And this is not the first time that this has been tried. So about 20 years ago, I visited a lab in Intel in Oregon where they set a home-based, developed a home of the future with all of these sensors. And they published on that quite a bit. And I think the idea was ahead of its time. The technology was too expensive, and the products never really materialized or scaled. But I think we have an opportunity now that technology is better to be able to integrate these systems. So they have to be accessible, clinical grade, secure, and fit into an ecosystem, which leads to the next point of what are the key interoperability agreements that we need to do, not only for data standards, but authentication and terminology, so that we're not building more silos, but these systems can actually connect data. And that's where the informatics piece is essential for this to actually work. Finally, I think of how we evaluate it. Of course, there are clinical outcomes that we can measure that we want to improve, but we also need to make sure that people understand what they're learning and have patient empowerment and self-efficacy. I think that's a huge role that schools of public health can do to make sure that that is part, an equal part of the agenda, not just clinical biomarkers. We need to see how we do communication networks between family caregivers, the healthcare providers, pharmacies, and how do we connect the dots and have better communication. We can also measure this in terms of quality of life, right? So perhaps it doesn't significantly increase your longevity, but that maybe 5 or 10% maybe by number of years lived, but maybe the quality of your life would have been better during that. And finally, how do we do this such that it actually saves us money and it's affordable and fundable? I think this is probably the hardest piece of it to understand, because all of these ideas are great, but somehow it needs to be funded. You know, there isn't a building code for home-based care that covers a lot of this. There's parts of it for home visiting nurses, but a lot of this isn't quite clear how to do that. And I think the way to do this is to show through these systems that once we deploy this technology, we can manage patients better, have fewer adverse events, fewer emergency room visits, and overall, the overall cost would be. So there's an upfront cost to installing and deploying it. There's a long-term benefit in the overall cost of healthcare. And I think that's why we need to talk to both insurance companies and healthcare providers and the government for how this will be reimbursed. And, you know, we've done that before. We incentivized the adoption of medical records through huge amounts of money from the US government. We've incentivized solar panels. And so I think home-based care probably needs an act of Congress to be able to do this with a sound way of doing this. And I think schools of public health have to work with medical schools and patient advocacy to make sure that agenda has that. And that's the kind of conversation that we want to bring together. We'll be organizing webinars. Happy to reach out to you as well to see how do we get more people involved in that. So some of the specific things that we want to do towards that, we're improving the medication labels, coming up with alternate ways of presenting that with graphics and videos. We're working on the informatics piece to how to encode that such that we can do smart filtering for that. We're developing protocols to evaluate both comprehension and ultimately what we really want to do, apart from just improving the education of understanding of that, is have better management of those symptoms and fewer adverse events. And that you can only do with a longitudinal study. So these are some of the reference that we have. And I think if you search for my name, there's a website you can find, and you can find the links. Most of them are open access. There are my, where you can discover me easily. There's not that many Yuri Quintanas. And there's only one of them currently at Harvard, although there's 3 other Quintanas at Beth Israel, which is great, but there's only one Yuri Quintana here. But really, have really benefited very much from the Memphis community. I spent 12 years working there. I met tons of people at the hospitals and at the University of Memphis. You have a lot of innovative things coming out of Memphis, and the FedEx Institute hosted a lot of great talks as well that I attended and participated. And a lot of original things have come out, not just rock and roll, but say rock and roll was a great thing that Memphis contributed. So thank you, and be happy to answer any questions.
So thank you so much, Yuri. This has been such a delight to listen to this conversation, and I'm sure that there might be some questions from the audience. But just out of curiosity, you mentioned cost, which is a critical component. I just wanted to a little bit understand more. Where do you see, what are some of the challenges, like 1, 2, or 3 key challenges in its uptake and in its adoption at a patient level and at a community level?
So I think currently some of these technologies are unaffordable to most people. I think if you're going to do home-based monitoring, you can buy wearable sensors. There are companies who will monitor you at home for a fee. That's great if you can afford it. But, we have challenging economic times. So we're probably going to have that for a long time. Those services are not cheap. And many people can't afford it. So you can pay out of pocket for it, but it's still a problem. You can go buy devices, and certain retailers increasingly sell, you can go online and different companies. It's interesting, 2 high-tech companies, and this is just for illustration purposes, not endorsement, but Best Buy is selling many more home healthcare devices. Philips, which used to sell light bulbs and other electronics, is now a healthcare company. They actually bought Lifeline. They're based here in Boston. And they have an app similar to InfoSAGE. We went to see them and we said, hey, that looks a lot like InfoSAGE. I said, yeah, we know about you. We've been reading your papers, which is, that's what we're supposed to do, is stimulate thought. So there's a bunch of other ones like InfoSAGE. But all these devices cost money, and the device, what do you connect it to? How do you then share that information with your primary care provider? How do you share that with your oncologist? Who pays for that, right? So the second observation I'd make is that clinical trials are really expensive to do. A lot of them do not recruit enough underrepresented minorities. So there's a huge problem. And even when you get the drug approved, people want to know how patients are doing in that drug. So there's a huge industry right now called real world evidence. it's really hard to collect that data. Right now, the way it's done is you have to have an agreement with a hospital, be able to anonymize the data, you license it to some pharma or some other group to analyze it. Very complicated, not easy to do. And so there's this other idea of how could we collect the data directly from patients? Where would that data sit, right? Who would govern that data? And so we have the technology to aggregate data. We have all these devices at home, but that data is sitting in devices that's not being used. And that's a lost opportunity to sort of advance healthcare, right? And both healthcare delivery and how do we improve medications. And so I've started a conversation with other people of how can we aggregate that data? Where does it sit? Who pays for that repository and the governance and the security? But if we were to collect that data, imagine then we could collect, instead of 10,000 people reporting adverse events, we could have 10 million people or 100 million people. And then the cycle time to be able to speed up that improvement would increase dramatically. So right now, if you have an adverse event, you report it to your provider reports it to the FDA, or you report it to the pharmaceutical. All that aggregation of data takes a long time. And by the time it actually gets somewhere, it's not actionable. And so we are sort of drowning in data that we're not using. And so I think apart from the healthcare delivery costs that need to be addressed, there's the biomedical research costs. Now, there are grants available for some of these repository real world evidence, but they're just that, they're time period grants. And so we need to think of a new model other than pharma trying to buy the data from hospitals or single person grants, because none of those are particularly scalable. And so I think, this is where I think public health could play a huge role. So for example, long COVID, and by the way, we are launching a seminar series starting in 2 weeks on COVID and long-term COVID studies. So there's a bunch of different groups studying that, and they have different databases. And so we want to know, how are we going to sustain those databases and how do we access that? And it's a public health problem because lots of people have long COVID symptoms. And so we need that data to be able to develop biomedical discoveries. We need that for public health. And so we will be hosting, starting October 12th, several series on a new website called dcinetwork.org, and I'll send you the link. But that will be for all of these groups that have large repositories. What's the sustainability model, and how do we make that data more accessible? It's a cost thing, but the cost is more than just money. The cost is the lost opportunity to find treatments for people who need it.
Thank you.
Yuri, I have a question. A wonderful presentation, very impressive. What I really liked about it, you're promoting a sense of community for vulnerable populations, and looking at health literacy and health equity. So I can see I can see this work, and also you're promoting interprofessional communication. So as you move to have this health communication in a more easily understood way, I'm thinking it could also support community health workers and their health literacy, and people who work in nursing homes, nurse aides, so that they can communicate better with patients and understand what the patient care is supposed to be. So kudos, it's a beautiful project, very interesting.
Yeah, I agree. I think those workers are essential to how we sustain. They're going to be even more essential as we, the number of people graduating from medical programs isn't really growing. The number of geriatricians, people going into it, is actually pretty flat and may go down. And so we'll need to develop a community-based approach to care.
And the training information for those individuals needs to be, culturally sensitive and culturally based and tailored. So a lot of great opportunities for public health.
Yes. So we're envisioning an Alicanto for home-based care, where we can share best practices for how to implement these home monitoring solutions, how to integrate them into healthcare system, how to work with community aides. And, in the work that I've done with cancer, especially in developing countries, social workers played a huge role in actually improving outcomes, because patients couldn't afford to come to the clinic, or their children were too weak and needed better nutrition. And so the social workers solved the problem of abandonment, which was 30 to 40% some countries, down to 5% or less. And so I think the social workers are sort of the unsung heroes in our healthcare system.
Thank you.
I think we
I see
Erica has a
Ann.
question. Yeah, Erica, go ahead.
Hi, thank you so much for your discussion. Can you guys hear me? Yes. Okay.
Yes.
So my question, I wanted to kind of touch on one of the last slides that you showed that had telehealth and remote monitoring. I am developing a remote monitoring technology to help monitor patients after surgeries, specifically hip and knee replacements for the development of venous clotting, which is a big problem in that population. And so one of the things that you mentioned also was about reimbursement, and how can we start getting some of these technologies and devices covered through reimbursement. I know that there are codes out there specifically for remote monitoring of chronic diseases, and also moving a little bit towards monitoring of therapeutic drugs and other types of therapy. So there is a little bit of a drift towards seeing the value here for a number of different stakeholders. One thing is really looking at how long it takes to show that value sometimes. And so one of the questions I have for you is, what are some of those surrogate markers that that people are finding to be really key to be able to show value quicker than, say, looking at mortality over 1 or 2 or 5 years? What are some of the most important, or what would be your advice in some of the most important surrogate markers to really be able to show value there?
So I think, we're probably usually too focused on mortality. And not that that's not important, of course it is, but we underestimate other indicators that are also hugely important. So for example, loss of productivity in not being able to go back to work, because that not only affects you, if you're the primary income earner, it affects your whole family, right? It affects the company that depended on you to do a certain job, who may not be able to then, it affects the supply chain, right? If you're, and that sort of was a dagger in our global economy when we didn't protect our frontline workers and our supply chain workers, and then they were sick and couldn't drive the trucks and couldn't show up to the emergency room, right? And so some of these health conditions that affect especially minorities and lower income members of our society have a trickle effect on the entire economy, which some billionaires are finally starting to realize that now that we've gone through this pandemic. So there's that one. The other aspect that I think would be interesting to look at is sort of racism, because in the case of knee replacement, some of these things aren't offered sometimes by the providers to some people because they don't think they can afford it, or they don't want to bother to look for what are community agencies that could help them cover the cost of that, right? And so it's easier if there's 3 choices, they'll send them to the one that's most convenient from the provider's end, right? Which is what Warner Slack started in the 1970s, is why don't we learn about patients' preferences and their condition so that we can help them find solutions that fit their needs. So in some cases, maybe if they were, and so there's been a growing body of work to understand implicit bias on the part of providers who may not be communicating choices to providers. And that has an effect not only on the patient, but it's hugely disruptive also to the healthcare system, because if that provider has biases towards the patient, they may be showing that sort of biases to other health professionals and creating a disruptive environment for that. So I think racism and bias have to be talked about, and you have to do something constructive. In our hospital, we adopted a system for implicit bias that was developed specifically for healthcare providers. It was developed at the University of Wisconsin. It's called BRIM. And we trained people. I was one of the people trained, and then these people then trained others on the BRIM. And so I think issues of systemic racism and inequality are things that need to be talked about in the healthcare system, because they're a contributing factor. And so how do we measure that we're making progress on that is another metric I think we should measure.
Yuri, thank you so much for this talk. Thank you so much for focusing on patient-reported outcomes. I know a lot of times we don't focus enough on patients and what they want. And given in light of the COVID-19, I know you had medications in the app. Is there any place that they are able to upload vaccination records within the app?
So not currently. We did add over-the-counter medications and herbals out of patients requesting, and that was, I think that's a great idea for next to be able to add vaccination records, because we do want to add symptom management.
Yeah.
And it'd be interesting to find out, how those symptoms correlate to how often you've been vaccinated.
Yeah.
We have this dilemma of what do we do with the data that people collect on the InfoSAGE app if they wanted to contribute that data to a COVID repository. Which COVID repository should we connect to, and what's the standards? Hence, that's why we're doing this discussion with all these other COVID repositories, for them to be able to say what's their roadmap, and do they want to connect to mobile apps, and can we have a standard to be able to do that? But I think right now we have an increasing loss of data of what's happening in the public health, because fewer and fewer people are getting tested through public agencies. Yet they're getting COVID, they're getting symptoms. And we don't really have a national public health surveillance system that's more real time. And that's hurting us because, if the best thing you can do is see how people are searching for symptoms on Google, that's not a very reliable index. I mean, it's better than nothing, maybe. But we don't have a systematic way of linking. And there's tons of mobile apps out there, but there's no strategy for where people can contribute. And if you could contribute it in an anonymized way, you could be assured that it was being managed properly, and it was truly anonymous, and someone was auditing those apps and those transfers. I think many people would contribute to a public health database that was, but we need a trusted entity, and we need a model to do that. And those are the discussions that our DCI network wants to host. And we invite you to join. And I love these questions. These are the questions we need to have more
Wonderful.
national discussion on.
Great. Thank you all so much. I think we'll cut our conversation here and on a great note like that. And thank you all for joining. We'll look forward to inviting you to our next talk in October. Thank you so much.
Thank you all.
Thank you,
Take
Megan.
care.
Thank you, Marian.
Good to see
Thank
you
you,
all.
everyone.
Thank you.
Take care.
Thank you.
Bye-bye. Bye-bye.
Bye.